Katie.
Hi, Hannah. How are you?
I'm good. How are you?
Doing okay.
Good.
Keeping cool.
Trying to figure out, I lost my good headphones. I'm like, one of those.
Can you see me?
Oh, hi, Sarah. No, I can't see you, but I see your name.
Oh, wait, hold on.
Hi.
Hannah,
How are you? How are you?
I'm good. How are you?
I'm good. It's so nice to see
Wonderful
you.
to see you. That's the only reason I'm here.
Oh,
You
no.
can tell
You're
how far back we go. Tell them how far back we go.
Oh my gosh, Katie, Sarah is like a very, very, very dear friend of my family. And
Well, to see you.
she's known me forever, forever.
Well, Sarah, it's so great to have you with us tonight. Thank you so much for joining.
Thank you for having me, and I'm also part of Raising Voices. I co-chair the Civic Engagement Committee.
Okay. Tell me
So
more
I sent them the link, and we'll see if anyone else comes aboard.
tell me more about Raising Voices.
Have you not heard of them?
I don't think so.
Gotcha. So it started right after 2016. And it was started by two women in Rockville Center, which is where I'm from originally, and now I live in West Hempstead.
Okay.
So they just kind of grassroots and formed a bunch of committees and whatever is happening and what you want to get involved in and try to get local community activities and really whatever we can do starts locally, think globally, act locally, that kind of stuff.
Great. Well, it's so great to have you with us, and thank you so much for helping spread the word about this thing, about our thing this evening. And I'd love to put our heads together on ways to collaborate in the future.
Thank you. They do have a healthcare committee.
Okay.
And they've done a couple of presentations. So one of the things that Raising Voices has done and was doing before COVID was a monthly meeting. And one of the committees, whatever it may be, would do a presentation.
Mm-hmm.
The healthcare committee did a couple of presentations. One of them was universal healthcare. They have it, why can't we? And they presented,
Mm-hmm.
How it was run in a couple of other countries. And we learned a lot and we talked a lot. And, it's, they try to be informative on different issues.
Mm-hmm.
There's a Unity and Diversity Committee, and they formed the Anti-Racism Project. So they present an 8-week course on anti-racism. A few things that have gone into action. Environmental committees that do cleanup, civic engagement that does voter registration, things like that. So we try to be active, but right now it's been tough.
Yeah. Well, thank you so much for joining us tonight and for telling me about Raising Voices. Oh, hi, hi, Carla. Welcome to the teach-in tonight. If you have a chance to unmute yourself and just tell me a little bit about who you are and how you heard of this thing, our Zoom tonight.
Yeah. Hi, everyone. I'm Carla, and I heard about this through the Progressive Long Island's Facebook group. I think, Shauna, you invited me.
Hannah, yeah, that's where I posted about it originally. Yeah, and we messaged back and forth. Yeah.
So I'm just really excited to help out any way that I can. I'm actually a new mom. I gave birth in January, and before then I didn't really know about just the disparities in just healthcare, especially when it comes to Black women, until I think she actually joined Alexis Farber. That was my doula. Hi, Alexis.
I didn't know that connection.
Hi.
She gave me a lot of really good information. Alexis, I don't think you even know this, but in our first meeting, like you mentioned about the disparities with childbirth and Black women, and that was like where I was like, yes, she's gonna be my doula because she gets.
Oh, that makes me so happy.
But yeah, I've done a lot of research about it, and it's something that I'm very passionate about. So I'm happy to be a part of the group.
Great. Well, thank you so much for joining us tonight, Carla. And Alexis, I was just having people introduce themselves and how they heard about the Zoom tonight.
Hi, I heard about it from my very dear friend Hannah, who I did my doula training with, like how many years ago, Hannah?
A long time ago.
Almost 10 years ago. Yeah,
It was like 10 years ago.
each other for a long time, and now we live almost in the same town. So
Okay.
yeah.
Great. Well, it's so great to have you with us tonight. I'll try to keep things, we'll try to keep things to an hour tonight. I'll probably spend the first like 10-ish minutes talking about like a little bit about who I am and how I got involved with the New York Health Act advocacy, and then maybe 5-10 minutes about the New York Health Act and where that stands now, and kind of how Long Island plays a role in getting it passed. But anytime you have any question, like, you know, small group tonight, so anytime you have any questions or to clarify anything, please just interrupt. And if there's, I guess if there's anything that you want to make sure that I get to tonight and it doesn't look like I'm headed in that direction, feel free to raise your hand and be like, will you mention this? Or I was curious if you could address that. And I'm happy to, talk about whatever you guys are most interested in. So I'm just gonna share my screen with you and pull up the slides I use. Let's see. So someone mentioned, or I think Carla mentioned, having heard of racial disparities in infant maternal health outcomes. And that's kind of where my journey into health justice activism began. I first, in New York City, Black babies are 3 times more likely to die before their first birthday than white babies are. And Black women or Black birthing people are 12 times more likely to die of pregnancy-related causes than white birthing people are. And I first heard that statistic in about 2016, when I was studying to become a midwife at SUNY Downstate Medical Center and working as a NICU nurse in the hospital that's affiliated with SUNY Downstate, where over 90% of my patients were Black. So when I heard that Black babies were 3 times more likely to die before their first birthday, I was like, holy shit, those aren't just like some statistics out there. Those are the patients I'm caring for in my NICU. Problematic, I didn't know that this disparity existed. Problematic that I can't begin to describe what's causing it. And I wonder if this NICU is a part of the problem because we're understaffed all of the time. We're much more likely to have medical errors when we're understaffed. And all of those medical errors are only affecting Black patients because of who we care for at this hospital. And that kind of wake-up call kind of started my journey into learning more about racial health disparities in New York City. And what I learned was I was right on all 3 counts. It was super problematic that I didn't know and couldn't explain what the disparities were, and understaffing at Downstate and lower quality of care generally at Downstate was a big part of what was causing that disparity. So in 2016, there was a study that showed that if Black birthing people were going to hospitals that were as safe as the hospitals that white birthing people were going to on average, the disparity in severe maternal morbidity rate would drop by half. So about half of the difference in severe maternal morbidity is because of the worst quality of care at a concentrated set of minority serving hospitals. So essentially, if you have 3 predominantly Black serving hospitals where almost half of Black babies in Brooklyn are born at one of 3 hospitals, and they all provide much worse care, that worse care ripples out to cause population health disparities. So it's not a problem with the patients that are coming to the hospital, it's a problem with the hospital themselves. And in 2018, we just have someone joining us. Hi, Sarah. Welcome. We're just getting started, so welcome and welcome. And we'll anytime you have any questions, feel free to interrupt. In 2018, a similar study was published that looked at racial disparities in NICU outcomes and found that it found 40% of the disparity was because of hospitals, and the other 60% were because Black babies on average were born smaller and more premature, which means if you match babies to, like if you match a baby who was born at the same gestational age and weight, 100% of the disparities were because of the quality in hospital care. So the research, so what does that tell us? About half of the problem is hospitals in New York City. What the research doesn't tell us are which hospitals are the problem and why they are providing such worse care. Well, the research won't tell you that, but I will. So in Brooklyn, we have, or about the same time these studies came out, a separate database came out that showed the percentage of birthing people at each hospital that were Black, as well as the severe maternal morbidity rate. And here I ranked them from the safest to most dangerous by the severe maternal morbidity rate, and then overlay them on a racial distribution map of Brooklyn. And what you can see is that the 3 most dangerous hospitals in Brooklyn are right in the center of segregated Black Brooklyn, are right in the center of the Black neighborhoods. And SUNY Downstate, additionally, like beyond that database, in 2017, while I was working there, Leapfrog, which comes out with safety grade for hospitals, out of 2,639 hospitals, only 10 got an F grade for safety, and SUNY Downstate was one of them. So literally one of the most dangerous hospitals in America. Here's a map of infant mortality in Brooklyn, and you can see again, the neighborhoods with the highest infant mortality feed into the most dangerous hospitals. So why is the quality of care so much different at these hospitals? Well, for the most part, because they get a lot less money to be able to provide care, and when it comes to healthcare, less is less. Like if you spend less money doing it, you get worse quality care as an output. And the main driver of this is differing reimbursement rates from health insurance providers. So this is kind of where the New York Health Act starts coming in, and where I started looking to single payer health for advocacy, because the main reason why these hospitals, oh, hello, we have a new guest joining us. The main reason why these hospitals have so much less money is because they serve a higher portion of people who are on public insurance, and public insurance reimburses the provider who's providing care at a much lower rate than what private insurance reimburses. So in New York, 2/3 of Black birthing people are on Medicaid, whereas only 2/3 of white birthing people are on Medicaid. And so if you have a hospital that serves like a high Black population, which because of the history of racial and socioeconomic oppression also is a higher Medicaid rate, you get a hospital with a lot less money to spend on care. So the fact that Medicaid doesn't reimburse equitably or doesn't pay enough to provide good care is tacitly admitted to within Medicaid legislation, because there's a separate pool of money called the Disproportionate Share Hospital Fund that's supposed to go to hospitals that serve a disproportionate share of people who are on Medicaid. And so where in states that use that money as it should be used, they have their racial disparities and health outcomes aren't as bad as New York. In New York, however, the money doesn't actually end up going to hospitals that serve a disproportionate share of people who are on Medicaid. There's a law in Albany that that takes this funding from the federal government and puts one pool in for part of it into a pool for the private hospitals to divide into, and the other part of it into a pool for the public hospitals to divide into, except for the money in the pool for the private hospitals is a lot more, and the private hospitals serve a lot fewer people who are on Medicaid. So you can see in this chart, the blue bars show how much money each hospital is spending on un- and underinsured care. And the orange dots show how much money they're getting back from the state of New York for providing that care. So we can see that the private hospitals, so this is NYU, NYP, Northwell Health, Mount Sinai, and Montefiore, these 5 private networks are getting reimbursed millions of dollars more than what they spent of just free money, and where the public hospitals are racking up tens of millions of dollars of debt each year. And beyond what, kind of like tangent, beyond what the reimbursement rates are coming through, we also see this structural racism in health financing, because SUNY Downstate is one of 3 SUNY hospitals in the state of New York. The other 2 are in Stony Brook and Syracuse. Now, SUNY Upstate and SUNY Stony Brook, their patient populations are 80 and 90% white, and they both are getting $50 million a year from the state government, whereas SUNY Downstate, whose patient population is 90% Black, was not until this year, I think because I started a campaign and started calling Governor Cuomo a racist for having done this. And somebody in his office was like, yeah, that is kind of racist. You got to give them their money back. And in this year's budget, we got the same $50 million as the other 2 hospitals. So care is different at downstate because funding is different at downstate. So how does, I guess an example of how this plays out is in 2017, there were budget cuts coming from the federal government. In 2012, there were budget cuts coming, and the hospital did not preemptively cut staff and services to their patients, and which caused a huge financial, we went into debt. And the conclusion from 2012 was not that the government gave us too little money. It was that the leadership of the hospital failed to properly anticipate for future budget cuts. And by not preemptively cutting staff and services, they caused their own financial downfall. So in 2017, when we knew that budget cuts were coming, the hospital started to incentivize obstetricians that had admitting privileges at more than one hospital to bring all of their patients to downstate so that we could get more reimbursement and increase our revenue. What they didn't do was hire any more nurses. So we were working shift after shift after shift, not like 1 nurse short, 2 nurses short. We should have had 15 nurses in the NICU, and we would have had 7 or 8. So on August 8th, I emailed my supervisor to say, this is really dangerous. When are we going to get more staff? I don't hear anything back. And the next day, a Black mother dies of preventable staffing related causes. I keep coming back to work shift after shift, and things are as bad as the day a mother died. And I send emails up the chain of command at the hospital saying, essentially, what the fuck? Like, somebody already died on a shift like this. How are we not getting more staff? How are we essentially not shutting down our labor delivery services and diverting people to a different hospital if things are this dire? I don't hear anything back. And in November, another mother dies. What I didn't realize at the time was the same time I'm writing these letters to my supervisors, the headlines in the news are Cuomo's holding on to, because budget cuts are coming in the future, Cuomo held on to money that was already owed to us that wasn't being cut, so we could get used to what it would be like to have future budget cuts. And so the reason why my supervisors were ignoring all my emails up the chain of command is because what were they going to do? It was already in the news that the budget was being cut, and there wasn't any kind of public outcry about how this would affect patient care. And so they just went ahead doing what they did. even though it killed 2 people. And there's never really been any justice at downstate. There was never any critical review of what happened on those shifts or how to improve care, because we didn't really have the staff to do that kind of critical review. And people just moved on. Hannah, I saw you, did you raise your hand?
Oh, I just put in the chat. I think somebody texted me they're in the waiting room.
Oh,
Sorry.
you? Thanks for telling me. It's hard to keep track of everything.
I know, that's so, yeah.
Great. So yeah, that's Joseph Topek, I'm assuming a relative of yours.
I don't know, he's like a guy. It's my dad. It's my dad.
Hi, Mr. Topek, thank you for joining us. So, okay, so if you pay a hospital less, they can't provide as good care as other hospitals can. And if all of those hospitals serve predominantly Black people, that is going to cause population level health disparities. So now let's talk about the New York Health Act. So the main way the New York Health Act is going to essentially fix the problem that I have just described to you is that once every New Yorker is on the same health insurance, every hospital gets paid the same amount for providing care. And if it's not enough to provide excellent care to every New Yorker, like every birthing person in New York, every birthing person in New York is going to know about it, and we will have a unified front there's one more. We will have a unified front to advocate to get a better insurance reimbursement rate. As it stands now, the folks who are most disadvantaged by inequitable insurance reimbursement also have the fewest tools to advocate for themselves to improve those conditions and to hold the hospitals accountable when they do not provide appropriate care. I think it's have me back for another teach-in on kind of the history of racial health disparities, but the racial health disparities in infant maternal health outcomes since chattel slavery ended have only gotten worse. So in 1850, the white-black infant mortality ratio was 1 to 1.5, and right now it's 1 to 2 to 1 to 3. So, and in 1935, which is the first year we have records for maternal mortality, the white-black ratio was, I think, 1 to 1.5, and now it's 1 to 5 nationwide and 1 to 12 in New York City. So you have to ask yourself, like, well, why is it that things are only getting worse? Well, I think it's because, the short answer is because we have never really addressed the inequities that started in slavery and have gone along unchallenged since then. And in us not being on a unified insurance plan, us having the piecemeal for-profit insurance that we have now is a part of that story. So in the 1960s, there was a conversation about we should go to a nationalized health insurance program, and it was the American Medical Association that at the time was segregated to be white, like they prohibited Black membership in the American Medical Association until the early 70s. And in the 60s, the first time that organization ever collected individual dues from its membership was to start a lobbying campaign against a national health insurance policy, because they realized if everybody had the same health insurance, white doctors would have to take care of Black patients, and there wouldn't be a mechanism to continue segregating their patient populations after racial segregation was made illegal. So it's the fact that insurance segregation exists and it's having a deleterious effect on the Black community is not a coincidence. That was kind of the intent from the beginning, was a racist disregard for how these policies could play out in Black communities. And so, in 1850, our Constitution valued most Black people as 3/5 a human. Well, our current insurance system values most Black people now at a half a human. So we see the, we've always had health disparities because we've always treated human life as if there was a hierarchy of value and as if some people are worth more than other people. And that is literally true in our insurance reimbursement rates. So if we go to universal health system and we're all on the same insurance, then it's as a society, it's us saying each human life is worth the same amount to save. And it's not worth twice as much for a white person to bring a child into this world than it is for a Black person, which is more or less which is the narrative that our current insurance system creates. Okay, that was more than 10 minutes, but thank you for bearing with me. Well, so a little bit more about the New York Health Act. The New York Health Act was written by Assemblymember Gottfried, who represents Mid-Manhattan in the early 1990s. It's passed in New York, we have Assembly and like a New York State Senate and the New York State Assembly. Which operate the same way that like the United States Congress and the United States Senate does. So it's two houses of the legislative branch. The New York Health Act has passed the state assembly almost 20 times. So we've always been able to pass it out of the assembly. And it's always been that the New York State Senate was Republican held and we were not able to get it out of the Senate. 2 years ago, that flipped, that changed, and Democrats had the majority in the state Senate. And it became much more, politically viable to pass the New York Health Act. So as it stands now, there are 63 senators in the state of New York, and 31 of them are co-sponsors of the New York Health Act, which means if one more, a co-sponsor is essentially a way of voting yes in advance on a bill. So the sponsor is the legislator who initially puts the bill out, and co-sponsors essentially by putting their name on that bill before it comes up for a vote. They're saying, yes, I support this. And when things come up for a vote, folks who aren't already co-sponsors and who may not know the details of a bill well will often look to see, well, who else is co-sponsoring this? Oh, all of the people who I normally trust their legislative decisions. Cool, and they go ahead and pass it. For the doulas in the audience, there was an issue with a doula certification bill being passed last year, and it was passed on the same day that 200 other bills were passed. So most state legislators have like 3 to 7 people on their staff. They even if all of them, their only job was to read each bill, they wouldn't have been able to like have an informed opinion on all of these bills. So they're keeping track on who's co-sponsoring. So 31 co-sponsors, 63 senators, we are one person short of having the votes we need to get this passed. Now, we don't say like we're one vote short because one vote short. Also, there are 40 Democratic state senators. So we often talk about the 9 Democratic holdouts. And that is because I guess we don't expect really Republican state senators to sign on to this thing. But here are the 9 state senators who are Democrats, but who are not yet co-sponsors of this bill. One of them, Andrea Stewart-Cousins, she is the Speaker of the Senate. So we don't say we're one vote short, because if somebody who's not Andrea Stewart's cousins signs on to be a co-sponsor and we have 32 co-sponsors, she could still choose to not bring it up for a vote. And then once it passes, Cuomo could choose to veto it. So like, we still have those are essentially the political challenges between here and us having universal health care, though, is essentially getting one of these 9 people to change their mind, or pressuring one of these 9 people to change their mind. Andrea Stewart-Cousins up until now has said like, oh, I'm not a co-sponsor because I'm the leader of the Senate, and so it's inappropriate for me to make a decision beforehand. So like, if another person signs on, then I guess we get to see if that was just talk, or she will, we'll bring it up for a vote. And then, so that is kind of like where the New York Health Act is at from a political or logistic point. And then the reason why I'm happy to connect with all of you wonderful folks on Long Island is because John Brooks, James Gaughran, Todd Kaminsky, Anna Kaplan, Monica Martinez, those 5 all represent districts in Long Island. So now let's switch over to my Long Island slides. So we think within the New York Health Act activist community, up until now-ish, the political strategy has been to put pressure on the 9 Democratic holdouts and essentially try to convince any or all of them to sign on to the New York Health Act. And then from there, we would go to pressuring Stewart Cousins to bring it up for a vote. Right now, we're in kind of a slight pivot or an additional strategy that is now viable now to November is by getting more senators who are in support of the New York Health Act elected to the state Senate, flipping districts from Republican to Democratic, and flipping districts from Republican to Democratic. And there are 9 Republican state senators who are retiring this year. So there are a bunch of seats, especially in upstate New York, that are, I think 2 in Long Island and a bunch in upstate New York that are open. And we can be putting pressure on the Democratic nominees to come out in support of the New York Health Act if they haven't already, and for the ones that already are out and in support of the New York Health Act, support their campaigns. So kind of district by district in Long Island, out in Senate districts 1 and 2, here 1 and 2, your Senate District 1, the current state senator is resigning, and the person who is running for the open seat from the Democratic, on the Democratic ticket is not yet openly in support of the New York Health Act. And same thing, I think there wasn't a state senator from the 2nd district for a while. Maybe there was a scandal, who knows? If any of you guys live there, fill me in.
No, I do.
Do you know why you don't have a senator right now?
He resigned early to take another job,
Okay.
but only a few weeks ago.
Okay.
Yeah, and he was the minority leader.
Okay.
He was the majority leader when the Republicans had the majority, and then it was John Flanagan.
Okay.
But he was a Republican.
That name rings a bell. So John Flanagan recently resigned. So Senate District 2 also has an open seat, and the Democrat who is running for that seat doesn't have much of a Twitter presence, and is not yet in support of the New York Health Act. Senate Districts 3, 5, 7, 8, and 9. Those are all the Democratic holdouts. All of them, I checked in 2018, all of them won their elections by more than 10,000 votes or more than 10 points. So they're pretty safe seats. And our strategy is like pretty much unchanged with the November election, because essentially if they don't change their minds and won't support the New York Health Act, really the only course for or the only recourse voters have is to vote them out. And the Democratic primaries were 2 weeks ago. So that kind of like long-term organizing is to put pressure on the incumbent, and if the incumbent is not movable, to find somebody to challenge them. And then lastly, in Senate District 4 is State Senator Boyle, who is not resigning, but is being challenged by Christine Pellegrino. And he won only very narrowly in 2018, the incumbent. And Christine Pellegrino is out in support of the New York Health Act and talks about it regularly on her Twitter feed. So this could be a very exciting place to get involved in, is by supporting her campaign and flipping that seat from a Republican to a Democratically held seat. And then Senate District 6 is Senator Thomas, and he is a co-sponsor of the New York Health Act, but I've heard like on the New York Health Act rumor mill is that he's a little shaky. And if it looked seriously like it may come up for a vote, he may retract his support if it's not clear from his constituent base that this is what they want him to do. And maybe we can understand Senator Thomas's shakiness because he is the Democrat in Long Island who won with the most narrow margin in 2018. And so he may be hesitant to go further to the left if it seems like his constituency is on the right. So as far as the, like, generally the ideas I had for folks in Long Island is if you live in Senate Districts 1 and 2, get in touch with the campaigns of the Democratic nominees, ask if they're planning on supporting the New York Health Act. If they are, volunteer for their campaigns. If they aren't, see if you can convince them to. I'm hoping, I teach a Twitter activism class on Tuesdays, which I'll hype to you guys in a second. But hopefully there'll be enough single issue voters around the crazy idea that everybody should have healthcare, that folks who are not already out in support of the New York Health Act decide to do that, kind of to tap into the activist energy that is happening within the New York Health Act community. We just have to create that activist energy to entice them to try and grab onto it. People in Senate District 6 and 4 support the campaigns of Senator Thomas and Christine Pellegrino, and folks who are in the districts of the holdouts. You can get started tomorrow during business hours, make a call, say, hi, I'm a constituent, I want to ask that Senator so-and-so support the New York Health Act, see what they say. See what they say, and then let's keep putting our heads together on strategies to continue to organize in these districts, to put pressure on them, and if they aren't movable, to find new folks for the years to come to make New York as progressive as New Yorkers are. So those are all my spiels. Thank you guys so much for coming and listening to them. What are you guys thinking about? What questions do you have?
I'm surprised to hear Monica Martinez isn't on board with this. I understand she's pretty progressive and she's got a lot of support from progressives. I don't live in her district, but
Leah does. Leah does, Abba. Just saying. That's my sister. That's my dad, and my sister lives in her district, so
yeah,
we're on it.
Okay, good.
Get
good.
all hung
All right.
Yeah, I wonder if she also is in this position. So I think what's really important to understand about state politics is how few people are paying attention to it. So I tweet at Monica Martinez every week telling her to pass the New York Health Act, but I haven't seen many constituents using Twitter to try and communicate with her to say, we want the New York Health Act passed. And if there aren't, and just because there aren't, it's not, we don't live in a world where if it's not on Twitter, it didn't happen. But if it's not on Twitter, it makes me wonder if no one has used Twitter to ask Monica Martinez to sign on to this. Has anyone called her office? Has anyone asked to meet with her? And so if the people who have money in this sphere to lobby are the health insurance companies. And so probably every year, someone from a health insurance company calls and makes an appointment and sits down with Senator Martinez and gives them the spiel about why we don't really need the New York Health Act and why, health insurance companies are doing a fine job, and just give them a little bit more time and we'll figure this all out with tweaks here and there. And so if the only people she's hearing from are the insurance companies and there's not a clear demand from her own constituents to sign on, then there's it doesn't behoove her politically to sign on to it. It would just expose her to risk and to negative attention perhaps in future cycles from insurance companies that have money and want to keep this from passing. So when and where that changes is like the money doesn't talk loudest in politics, votes do. And so like to the degree that money has power in politics, it's because people assume or see how money is used to try and get more votes. But I think what many progressive, like the increasingly progressive candidates that are coming out, especially in New York City, and we just had 5 socialists won their primaries to go to Albany out of Brooklyn and Queens. And those socialists did not have money. Like, though they did not have, I think their average donation was like $17, $20, $30. Very few, if any, big donors. Many of them like intentionally did not take donations above a certain dollar amount. And so they only are going to adopt policies that benefit their voters because that's who they're paying attention to. So a health insurance lobbyist coming in won't sway them one or another because they only got elected by putting in a lot of work into developing grassroots support from their districts. I don't know if Senator Martinez has that kind of, feels like she has that kind of loyal voter base, because I don't think she was elected using the same grassroots strategy that some of the socialists were. So if she's not hearing regularly from constituents that this is what they want, then the money from the lobbyists does speak louder. So I think often there's so much focus, like all of the news is only on the federal politics. Like when people think about getting more involved with politics, they always think first about like calling their federal congressperson. I've been trying to organize at state level politics for a year now, and like I can't tell you how many conversations I have with somebody, and like halfway through they're like, well, Hakeem Jeffries is my state senator. And I'm like, no, he's not. He's a congressperson. A different thing. But like I teach a Twitter class, to like a Twitter activism class, and the idea for that came because somebody retweeted something of mine. Like it got like maybe 20 retweets to a state senator in Brooklyn, and the next day I got a call from his office saying, we heard you wanted to meet with us. Are you available next week? And I was like, oh, you guys you read your Twitter. And that's what I realized. Oh, right. These people only have like 3 to 7 staff people on staff. So if many senators operate their Twitter themselves, and if it's not them, then the person who does it for them, like works really closely to them. So I think a lot of the hesitancy from the Democratic holdouts is because they're just not hearing, it's not a clear demand from their constituents to sign on. Or at least I'm hoping that that's the case, and that when there is clear demand from constituents, we see that flip.
Katie, question. Hi.
Hi, Sarah. Thank you so much for joining us.
Yes, we have a young constituent here as well.
Hello there.
Is your thought, just because of the possibility for amplification and like how public the Twitter posts are, that like that's just way more effective than calling, or should it be like multi?
I think it should be. So the thing about the thing about calling is like when you call, you're going to talk to a real human, and like if you call, you're going to talk to a real human, and if you call back, you'll probably talk to that same human again. So as far as like, once you call the first time and say, hi, I'm a constituent and I want him to sign on to the New York Health Act, if you call back the next week, they're just gonna be like, oh, okay, cool. Like, we got your like, eventually they're gonna recognize you're all this one person just calling me the same time over and over again. And so as far as like a strategy to keep sustained pressure on elected officials. I think Twitter works well because it does keep it in a public sphere. It's a little less harassing maybe to the individual staff people who work for these state senators. And because I guess, sorry, Sarah popped out and popped back in, so I may repeat a minute of that for her.
Sorry.
No worries, Sarah.
I'll just sit tight and follow where you are.
Oh, that's what was I saying again?
I didn't hear any of the answer to my question because my internet, I don't know, dropped me. So.
Yeah, no, that's what,
About not harassing their employees.
yeah. Oh, tweeting versus calling. So I think the first time you call, like the first time you call, you know, ask the name of the person you're speaking to, write it down, and keep it, like if, but essentially, yeah, if you like calling the office over and over again, you're usually going to be talking to the same receptionist who's picking up the phone. So like, there's only so much she can do as far as convincing the state senator to change their mind. And if it's just you that's calling, she, like, after a while, I imagine she's going to stop communicating to the senator that, like, oh, the same constituent keeps calling me over and over again. Whereas tweeting at them over and over again gives the opportunity to engage the public in the advocacy that is happening. It keeps it on their radar without maybe, and with hopefully maintaining better relationships with the person who answers the phone at the office. I think it would be super powerful if lots of different constituents are calling into the office, and if they're getting calls from different people every day for the New York Health Act, that is definitely its own great strategy. It's sometimes hard to find lots of people who are willing to make those calls. So both at the same time, I think is the right answer. And while I have you guys, while we're on that note, I teach a Twitter activism class that doubles as a mini social media action for the New York Health Act every Tuesday at 2. They're called Twitter Tuesdays at 2. So hopefully it's easy to remember. So I'm teaching that tomorrow. And every Tuesday for the foreseeable future at 2. So if you're not on Twitter yet, I would love, I think everyone should be on Twitter for just this one skill. Not everybody needs to be on Twitter for the normal purposes, but I think it's, especially in a time where it's difficult to protest in real life, learning how to use Twitter to put pressure on electeds is super useful, and it's what I teach on Tuesdays at 2. So if you don't have Twitter yet, make yourself a handle and come some Tuesday. And if you do have Twitter, just show up, and I'll get to walk you through kind of the specific ways we're using Twitter to bring attention to the New York Health Act and keep pressure on the.
And we go ahead and post right then and there when we tweet right then and there, rather when during the class, or it's the how-tos.
Exactly.
Okay.
Exactly. So usually there's at least one person at the class who's never been on Twitter before. So we go pretty slowly with like, I share my, am I still sharing my screen?
Yeah. Catherine, what's your handle on Twitter?
It's at Brooklyn Grows. See, this is, so one way I was using Twitter is I was going through all of the Democratic candidates who are running for office for state senate in November. And some folks, like 2 or 3 people had in their health insurance or like health section on their websites, like, you know, we believe healthcare is a human right and everybody should have universal healthcare, but it didn't specifically say, and I'm in support of the New York Health Act. So I tweeted at one of them and said, hi, any chance you saying you're in support of universal healthcare means you're in support of the New York Health Act? And she said yes. And so now she's on the list.
Oh, wow.
of people to support. So I'll just show you because I spent so much time on this yesterday, and it's the pandemic, so I don't have lots of people to show off the work I'm doing to. But this is a database that has all of the senators in the state of New York, and then by here I have a code as like if they're a co-sponsor in a safe seat, a co-sponsor in a swing seat, running for an open seat in support of the New York Health Act, running for an open seat and not yet in support. You get the idea. But essentially where I'm working with a graphic designer, and hopefully we're going to create like an interactive map that's like shows you wherever you live in New York, how you can get involved in the fight for healthcare for all.
That's impressive. You really put the work in here. This is really, I'm like amazed. Wow.
So thanks. So I love a good database.
Of course.
I love it. So, and while we're talking about that, so the other database that I like or that I use regularly in the organizing work that I do is, and I'm just gonna send you a link in the chat box. When I haven't been reading the chat box, sorry if there's, oops, let me put that to everyone. Let me see. Okay. Great, so I'm just seeing some questions here in the chat box. So I just sent you guys a Google form, and one of the main ways that I organize, especially for the birth workers in the group, is by keeping a database of folks who are interested in doing this kind of organizing work by with your address where you're registered to vote. And then I have all of the, like your state senator, your state assembly person, your congress person, etc. So that way, like I can see, oh, we need XYZ person's vote on this bill, and we can look automatically to see everybody who's in that person's state senate district. And for the birth workers in the group, I'm really hoping that this grassroots lobbying network can be an engine for getting a lot of reproductive justice and birth justice type legislation through. So please give me your snail mail address and fill that form out to keep so we can keep in touch about the organizing work that I've been doing. And then also my relationship to the official Campaign for New York Health is, who knows, like I'm good friends with everybody who's officially on the campaign, and sometimes like they invite me to do things in which I'm an official volunteer, and other times I just do things because I know they're helpful and I don't check with them first because they're busy. And which is all to say, go to the Campaign for New York Health's website and sign up to get email updates from them, because sometimes they're doing stuff that I don't have time to send out to my listserv, vice versa. So it's good to be connected with the main campaign and keep tabs on the things they're doing. I see some questions, some folks sent me questions privately in the chat, so I'm just gonna answer, before I answer them, any burning questions at the top of your, so someone says, can you explain the difference between universal, single payer, and Medicaid or Medicare for all, please? From what I can tell, the difference is all of that is just branding. And it's not that universal healthcare refers to one type of program and single payer refers to a slightly different type of program, and Medicare for all is a slightly different third program. From what I can tell, they're all just different ways that activists use to try and describe what it would be, this crazy notion of having guaranteed universal health care that the government is largely involved in operating and administering. So Medicare for all, just, I think, Medicare was a super popular program, so somebody was like, oh, Medicare for all is a good branding tool to trying to describe this. Other people push back on that because Medicare doesn't cover everything that it should, and the New York Health Act the New York Health Act covers more things actually than Medicare does. So it's it's a step up from Medicare. But I often will still call Medicare for All just because like that's the parlance. I think the Campaign for New York Health likes to use the terms universal guaranteed because as opposed to single payer or Medicare for All, because single payer is a very wonky term that doesn't really mean much, and because of the issues with because some people have valid issues with Medicare as a program, but generally the program is what we make of it. And so the New York Health Act, I think, is a very strong program as is put together, because for the past 20, 30 years, various activist groups have gotten involved and worked with the legislative leaders who've been in support of the New York Health Act to say, like, this is what the disability community needs from their health insurance. Can you make sure it's written into the New York Health Act? And they have. So long-term care is included, home care is included, vision, dental. Like if you have a body and it needs care, for the most part, the New York Health Act covers it. Kind of the one major exception to that, again, for the birth workers in the group, is that we haven't really had an organized activist voice in the past 20, 30 years. And I'm not aware of anybody from the doula, midwifery, reproductive justice community getting involved to say, like, this is what we would need to make home birth available to everybody. This is what we would need to make proper lactation support available to everybody. So I'm having a hard enough time just getting birth workers involved in like knowing that this exists and doing anything to get it passed. So the next step of getting us to issue recommendations, I'm kind of shelving for now, but putting it out there, like essentially all that needs to happen is for us to talk with one another and to come to consensus conclusions and then communicate them with our senators. So there's a 2-year implementation phase between when the New York Health Act gets passed and when we would like fully be on universal guaranteed health care. So I guess my thought is like, if by some miracle this gets passed soon, that's like, then I'll just focus, instead of trying to get birth workers to get the thing passed, I'll try and get birth workers to evaluate it and issue recommendations so that by the time it does go through, we have what we need from it. Someone asked, why are there Democratic holdouts? So like some of the narratives in New York right now is New York, compared to a lot of other states, actually has a really low uninsured rate. So less than 5% of New Yorkers have no insurance at all. And so that has led to a lot of people saying like, so what's so wrong with the system? Let's just like, why, instead of scrapping this whole thing and creating something new, let's just create a health insurance plan that will cover the last 5%. And I think this is maybe where the advocacy work and the perspective I come to the New York Health Act is really important, to say like, it doesn't matter if we have 100% of people covered by health insurances, but half of them are on a health insurance that doesn't pay enough for them to get quality care. We still haven't fundamentally solved the problems causing racial health disparities and health inequities within the state. So I think when I in May of last year, I went to give testimony in support of the New York Health Act, and there was probably over 12 hours of testimony. I sat through almost all of it, and I think in the 12 hours, 11 hours were of people who were speaking in support of the New York Health Act, and maybe 3 other people mentioned racial health disparities and mentioned like the inequities within the insurance system itself. So I think a lot of the focus is just on like covering people who don't have coverage. And so if you think, oh, we're just one step away from covering this last 5%, there's not the urgency to move towards a universal system, and having more people speaking out on the inherent inequity of a divided system, I think will be important on getting the last holdouts to flip to our side. and I felt with you know, thinking about the racial inequities of this bill and how it plays out, 94% of state senators who are not yet in support of the New York Health Act are white. So there are only 2 legislators of color, Andrea Stewart-Cousins and Monica Martinez, who are not yet co-sponsors of this bill. As white people, that does not mean we go to the 2 people of color and say, you should sign on to this bill because all the other people of color on. That means we go to the white people and say, hey, legislators of color who represent predominantly communities of color in the state are clear on what they need for equitable health insurance, and it's the New York Health Act. It's us who's keeping that from passing. Pass it, and then hopefully constituents of Stewart-Cousins and Martinez can make the cases to them for why they individually need to vote. And then someone else asked, when does this go for a vote? So the, like, kind of, we don't want it to go for a vote until we know that it can pass. So the leaders, like, we won't ask the leadership of the Senate and Assembly to call it up for a vote until we have the co-sponsors that we need. Because if we call for a vote and fails, then it's like a complicated process to get the bill reintroduced again. So before, so there's not like a scheduled date by which we need to, you know, we're not working under a deadline because it's being voted on a specific day. On the other hand, we are working under a deadline because New Yorkers really need this. And the sooner we get the last co-sponsor to sign on, the sooner we can then shift our energy away from just getting the co-sponsors to sign on and focus it more on the speakers of the House to have them call it up for a vote. And then lastly, I see here, if the country goes with it, then New York doesn't need it. If not, do you have to stay in New York to keep it? Okay, so that's a great, so that, that's another issue with the holdouts, is that there are 2 holdouts, Skoufis in upstate New York and Gaughran from Long Island, who were in support of the New York Health Act when they were running for Senate. And the reason they are currently giving for why they are no longer in support is because of the Trump administration. Essentially, Trump administration, Trump's being Trump, and they said that like the money that the federal government gives to New York for Medicaid, we wouldn't be able to use for the New York Health Act if we replaced Medicaid and Medicare with the New York Health Act. So but essentially that is no longer a valid reason because the main legislators in support of the New York Health Act have created a loophole that would essentially like shift the money from one place to another and make it usable again for the New York Health Act. And then if you have to stay in New York to keep it, this is one question that I'm actually not so clear on. And I think this is why Diane Savino says she's not on the bill, who's the senator from Staten Island, is because the unions are worried, like, well, what if people who work in New York retire out of state? I'm not sure, but get involved in New York health advocacy. And if that is one of the reasons that your senator gives for not signing on, we will get in touch with the main campaign and say like, hey, what's the issue with people who live out of state again? I know they're like, it's either recently they came up with one or they are working on a loophole, or not a loophole, but like a contingency plan for what about people who live in Jersey and work in New York or vice versa? How do we take care of them? The answer is like, we just figure something out creatively. There's no reason why we can't do this just because of those things. We just have to figure it out. And then as far as like Medicare for All on the federal level for the country, like, is great and I love it. And it's just not politically viable for the time being. Like, we would have to flip the Senate, the federal Senate. And I don't see that. I don't think that that's going to happen. Hopefully I'll be proved wrong. I'd love to be proven wrong on that, but I think it's going to be a while before we're at a place to be able to do this nationally, whereas we're already situated in a place to do it now in New York. And a lot of times the way that progressive legislation works is either New York, California, a progressive state will trial it out on the state level, and when the rest of the country sees it's not doom and gloom and sees it, you know, working successfully and people are benefiting from it, then state level policies get adopted on a federal policy. So I think as New Yorkers, like, the most effective thing we can do to try and get Medicare for all at a national level is to focus on getting it operating on the state level. And if we can show that it works in America, I think that, and like, if diabetics aren't dying all the time because they can't access their insulin, like, people are going to recognize New York will be doing better. Hopefully people will recognize that, and that will be important in the national conversation of being able to make Medicare for all politically viable. So great. Sarah, thank you so much. Yes, I'll love to get your mom's address later, and we will let you know who for her to pressure. I think those were all the questions in the chat. Any other questions or things that you thought of as I was talking?
I just want to say thank you to Katie. I encourage everybody to do Twitter Tuesday. I feel like I knew Twitter, and like I've gone on bits like at different times in my life, and I never realized how effective it can be. And I never really knew how to use it, because I think it is a little bit different than other social media platforms in terms of like the way you taught me, like to follow the hashtags and stuff like that. Like even just in my recent tweets, like I've seen like other people have like retweeted, not like, and you know, it's just really cool to be able to like work with other people in that way. And I also just want to say that personally, I didn't even know really that that there was this opportunity for New York to have healthcare for all. So I'm even just on like a very simple place of just trying to promote it and say like, this is a possibility, like this is a real, like this could happen, I think is really enormous. That I feel like I mean, at least Lex, like I know in our neighborhoods, I don't feel like anybody would even know that this was on the table, let alone that we had a Democratic senator that we could like tweet at, you know? So I think this is just really cool if we can just continue to like talk about it and put it out there. And just the idea of like going on Twitter is such a simple way to really connect and promote what's happening.
Thank you.
Catherine, this was really awesome. This was great. Thank you so much for, you know, volunteering your time to do this. This is really, really, you know, helpful. So
Yeah.
I didn't know any of this at all.
So like another little plug for like the doulas in the room, like I would love to be able to like get some work to put in, like, cause I'm just even thinking like in our areas, like if we were to look at like the breakdown between like who's going to Newmick, you know, and I don't know what other, like Mercy Hospital and these kind of hospitals versus like LIJ, like I'm certain that the disparities are enormous. And if we could talk about that,
There was,
you know, even like Martinez, like Abba, like let's think about like who's out there and going to which hospitals out east, you know, like these, like this can be like very, very tangible data.
right. There was a study that was done. I saw it when I was doing the birth
Justice Warriors.
It was between Merrick and it was either Freeport or Hempstead, and it was not good. It was not good.
No, I mean like we know this is what's happening, and who it's impacting, and I think that's really, really important for this.
Yes. Yeah, absolutely. Catherine, are you involved with the Birth Justice Warriors group? Are you familiar with them?
I've seen them, and I think I've talked to other people like you who, because you're generally interested in reproductive justice, have popped up both places. So that is a connection. Pretty much all the birth justice folks who work out of Brooklyn, I am well acquainted with, and now I'm just starting to poke my head out and see who else is working on this throughout the state. So I hope to connect with the Birth Justice Warriors soon, to put our heads together on a statewide organizing.
Yeah. I feel like you could be beneficial even to Birth Justice Warriors. I mean, obviously, it's run by Black women, and I wouldn't want to hijack that at all, but I think that you bring a certain knowledge of the Twitter stuff, and you're so organized with all of your information that I feel like you could bring a lot to the table to really help that organization a lot. So
yeah, really. So the other thing I'm working on is
there's more.
So the two named things I'm working on, there's Equity for Downstate, and that was the campaign I was working on that was focusing on the $50 million and reducing racial health disparities by eliminating racial disparities in health financing. The other thing I'm doing, so the database I mentioned before, which is mostly birth workers and birthing people, where I can look at y'all by district, that is, I'm hoping becomes, or is a movement to birth liberation, or becomes an organization that is a movement to birth liberation, which would be a reproductive justice think tank and grassroots lobbying organization. So the think tank part, I'm hoping, was mostly taking the things Black women have been telling us for decades now we needed to do, and taking the things they've been telling us we need to do for a long time that already is in legislative form, like universal health care and reparations, and actually mobilizing folks statewide to get those through. And then also, once, I think there's a good reason to not spend a lot of time developing progressive reproductive and birth justice legislation right now, because it's not politically viable. We could write a bill I could write a bill in 15 minutes that says we should have universal paid income for 29 months after you give birth, so you can actually breastfeed for 2 years. And if you want to go back to work, cool, you have a $40,000 of income from the state, so you can hire super high quality child care that doesn't exploit the child care provider. What a crazy idea. Not exploiting
our lives would be.
Right? So it would only take me 15 minutes to type that out. From here on forward, we will give $4,000 a month or $1,000 a week, whatever, to a family after they give birth, and for 24 for the birthing parent, 4 months for the non-birthing parent for the birth and for the 4th trimester, and a month to a person of your choice, and or can be used as a labor support stipend. So either your sister can take off work and do childbirth ed with you, and she can be your sister doula, or you can hire a doula themselves and pay the doula a living wage because you got a stipend to be able to do that. So cool, progressive idea. Let's make it into a law. Why am I not typing that into a law? Well, if we can't get universal health care through, why do I think we're going to be able to get a universal basic income through? So, and because of white supremacy and because of structural racism and how our state is governed, we're a predominantly white state. So for any of these policies to get through, it means there needs to be quite a lot of organizing and support in the predominantly white districts of this state. So what I'm really hoping to be able to essentially offer to birth justice warriors and other Black reproductive justice leaders is a lobbying organization, or is the lobbying potential to actually see through the things that I'm learning from them we need to move towards a society where we birth in liberation and more liberated. So if I'm not reaching out to the Birth Justice Warriors right now, it's just because I don't feel like I have anything to offer them, because I'm hoping to say, like, what kind of things do you want to get passed? Because here are all these organizers throughout New York who will work to getting in touch with their district, with people with their own representatives to get it passed in their own districts. And we're just starting to have that come together and be developed.
All right. Well, that's very impressive work you've put together so far, though. I'm really, really impressed. It's really awesome.
Well, guys, thank you all so much for joining tonight. If you get a chance, please fill out that Google Doc so I have your information. Follow or go to the Campaign for New York Health and give them your information so you stay on their mailing list. And hopefully I'll see you at a Twitter Tuesday, or we'll keep you in the loop from there, from the information from there.
Yeah. Awesome. Thank you so much.
Thank you, Katie. Thank you so much.
Thank you. Having you guys. Thank you all for signing on.
Bye, guys.
Bye.
Bye.
Have a good night.
Everyone have a good night.
Good night.